Hey, Joe. Good afternoon. All right, finally we get Tribal Health. Well, first of all, welcome and thank you guys. We appreciate meeting with you guys today. It's been a while since we had a Tribal Health Committee meeting, and so I know at one time we had a lot of questions, and so hopefully we can back on track again. And before we get started, I just want to congratulate you, Joe, on your appointment as a director. It's very good to see one of our own people taking the lead, taking the charge, and our health industry here, and making sure that our membership are getting the care that they need. So congratulations and thank you.
Well, thank you so much, Mr. Vice Chairman. I am very grateful, very thankful for the opportunity to lead the Tribal Health Department. Thank you for your confidence and Patty's confidence in me to take on that task. I look forward to improving, the services we offer and the health status of our community. That's what I would hope to do in the next few years. So again, thank you so much for the opportunity. It's hard to serve biscuits and gravy at an afternoon meeting, but hopefully next time we can maybe have you down to one of the buildings and host a health committee meeting there.
All right.
We shared with you an agenda. I also brought, maybe I should mention, Dr. Fox from the Tribal Health Department. Dr. Fox is our Behavioral Health Division Director.
All right, welcome, Dr. Fox.
She is. She leads our mental health and our substance abuse programs in the department. So if you have questions, and she's very heavily involved with some of the other departments in the tribe. I know she works with the Defender's Office. She's been involved in some of the tribal jail stuff and education. So she's very integrated in some of the other departments for the tribe. So she can speak to some of the programs.
It's good to hear. I've already heard great things about you, Dr. Fox, and welcome to the team, I should say. I know you've been here for a while, but just want to thank you. We're very grateful to have somebody of your stature on our staff. So thank you.
Thank you.
Mr. Chairman, we have an agenda, and I'll just kind of work my way through it. If you have questions, please ask them as they come up, so we can get those addressed. First, if this agenda is okay, we've identified. Oh, Patty, go ahead.
So if I can, one of the things that I want to say is, as we bring back the health committee, I think one of the things that, Joe and I are looking for is some advisement on really what you want to hear as we structure a standardized agenda moving forward. So we'll listen for those things. So as we put some structure to what the health committee looks like, we're taking that guidance directly from you.
Okay.
So thank you.
Thank you, Patty. That's correct. So we've prepared an initial draft agenda, try to work through this. Again, if you have some recommendations or additions you want added to this particular agenda as we move forward with the health committee, please let us know and we'll make those adjustments. The first item, if you're okay with this agenda, is the ordinance that establishes the health department, and it has some language in there identifying the formation of a health committee. I just wanted to get that in your hands. We have, I guess, a later part of the discussion is how formal or informal you want the health committee to operate. We've got a draft bylaws, if that makes sense, as far as how you want to structure this, or we can just be much more informal and have those discussions as a health committee and then take direction in that way. So included as part of the package is that document establishing the health department and the health committee. So I know we just gave it to you. If you have questions about it, it's available to you to review. So,
Okay,
Okay.
very good.
okay.
Okay,
Mr. Chairman, second item was a discussion from the Behavioral Health Division. That's why Dr. Fox is here. I've asked her to kind of prepare a summary description of the program, maybe some of her recent efforts and maybe some of the goals in front of her, and then be available to answer any questions that you may have about the program and services available. So
okay.
I'll turn it over to
Okay.
Dr. Fox.
Thank you, Joe. So I prepared just a brief overview of some of the services we currently provide, some of the programs that we have in place and partnerships. And I can touch on some of our future directions, but really I'm open to questions that you may have or suggestions you may have that we're not already pursuing. So to begin, our behavioral health division covers mental health, addictions, as well as some of the prevention programming under tribal behavioral health or under tribal health. We currently offer under our clinical services, we are currently offering patient preference for their clinical services. So that means they can either choose telehealth or in-person services. We're hoping to expand those in-person services as we bring our staff back on site. Currently, we have 15 clinical providers between LCSW psychology and licensed addictions counselors. Within that, we also just brought on a licensed neuropsychologist to do neuropsychological assessments part-time.
Dr. Box,
Yes.
how many employees do we currently that are still teleworking?
That are teleworking, I would say, so a lot of our staff are currently hybrid. So they do part telehealth, part in office. For full telehealth, I would say there's maybe 3 or 4 staff that are providing their services fully remotely. I have talked to the staff about when our community transmission levels of COVID reach the low levels again, that everyone will be expected to have 1 to 2 days on site, and then they can maintain their 2 days remote. A lot of that is spacing issues. If everyone came back on site all at once, we wouldn't have a place to put everyone.
Okay, thank you.
And so we are creatively approaching that hybrid schedule, but everyone will have an expectation to have an on-site presence, mostly to be able to offer in person at all clinics. So right now we have plans to have representation at behavioral health in all clinics at least 1 day per week. We also have, currently we have 1 clinical psychology graduate student working under my supervision. We'll be bringing on 2 to 3 more in the fall. And that just helps expand the number of direct clinical services that we can provide under the supervision of our own providers. Currently, we're receiving about, for behavioral health, for mental health specifically, we receive about 16 new referrals per week. Our staff is reporting that about 8 of those are resulting in direct scheduling of a follow-up appointment. The issue that has arisen with the ones that go unscheduled are either they're duplicate referrals, so they've already been referred for service, or there's issues with no contact with the person after they've been referred. And so the procedure we follow right now is 2 phone calls to the known phone numbers, and then we send a letter and wait for a response, and then close out the referral. In the times that we have contacted some of those individuals, sometimes the issue is they didn't want the referral to behavioral health in the first place. So the referring provider put in the referral even though the person had already declined it. And so that's been one of the primary reasons. And then the other primary reason is we can't reach people after their referral has been placed. So one of the areas that I've implemented since I've come on to help with some of these referrals that are falling through the cracks is implementing the same day access program, which is We have therapists available to our primary care providers and other tribal health providers that if they have someone that they're identifying needs to be connected with behavioral health, they call an extension and they immediately get connected with a therapist. And that person can meet with the therapist right then or schedule for a follow-up within that week. And so that right now we have 6 of our staff are fully trained to do those brief assessments. Right now, we're currently rotating 4 to 5 of our staff and covering those shifts. And so those, right now, our warm handoffs, we're probably getting about 5 per week. And we're hoping to increase that as the program is more established. And so the goal is some of these referrals that are being placed through our electronic medical record will actually be placed with a direct warm handoff to a therapist and hopefully reducing the number of people we lose, because we don't have their contact information up to date. The warm handoffs are designed to be kind of an early intervention strategy where we're targeting individuals who are coming into primary care appointments specifically with mild to moderate mental health conditions that potentially would not otherwise be noticed or recognized, and they're not coming into behavioral health for these issues because they feel like they're still minor and manageable. And so what this does is just accelerates when they're getting into care before these issues become more severe. Any questions so far?
Questions, comments? Yes, Jennifer.
I'll have more. What kind of group therapy are you providing for people? Because I know that's really effective for lots of reasons. Is
Yeah.
tribal health providing group therapy for adults or kids?
We do have offerings for adult groups. We haven't had great attendance, and I do attribute that to a lot of them have been virtual. And so there hasn't been great attendance to our virtual groups. And when we switch them to in-person, we also haven't had great attendance at in-person. I personally have offered several groups around health-related issues. So I've done groups for insomnia, smoking cessation. I'm running a chronic pain group right now. That one actually has had some pretty good response to it. And that one is in person currently. And so we're restarting that group beginning August 1st. But so far, having run it once already, we've had pretty good response to that. We do have plans to implement addictions-related groups. The one person who was going to implement that is leaving our team. And so we do have to identify someone else who will take on those groups. But those were also intended to be in person. We've had inquiries to our staff if they would be interested if we ran something like an anxiety group or depression group, and most of their individual patients have declined and said they would prefer to do one-on-one. But we haven't trialed offering it out to the community to see if we did get interest in attendance to those. So I agree. I love groups, whether they're virtual or in person, but it's a great way to not only reach more people, but also build those peer supports within the group. And so they're building a kind of a community around not just the therapist, but around each other.
Just to follow up, I know that more soldiers die by suicide than from combat, and that we have the highest, natives have the highest representation of, in the armed forces. And so are you doing groups, ongoing groups for PTSD?
We are not. We did an evaluation of the number of veterans that we have coming through, and that was a project in collaboration with John Wheeler for grant funding that was coming through. And we did not identify very many veterans who are using tribal health services, and it appears they're using the VA services directly. But that is something, again, that we could offer out to the community and see if that brings some of those patients into our facility.
Jennifer?
So this morning we had Craig Couture come in, and he said that he approached you, or tribal health, maybe it was Joe, but he said that he approached tribal health about getting a mental health worker assigned to the law and order department. And I think that's a brilliant way to go, because I think a lot of what they're dealing with is mental health issues, and then mental health becomes criminalized. People who shouldn't be in jail get incarcerated because they really need mental health care. And so I would love to see a mental health, at least if one, if not two mental health care providers working with the jail, working with police officers.
Yes, I agree. And I don't know if Joe had a different conversation with him, but currently we are working towards our own emergency on-call response. So they wouldn't be housed in the jail, but they would have access to that on-call provider to do emergency assessments in the jail. And we were partnering with the defender's office because they have their own mental health providers who go and access the tribal jail. But if there's a need to have kind of someone specifically assigned there, I think that would be well supported within our teams, because it is a high need, and a lot of the referrals that the tribal defenders get, as well as our facility gets, are people who are currently incarcerated. A lot of the warm handoffs that I mentioned earlier through the same day access are individuals who are in the tribal jail who go over to SKC for medical care, and SKC calls us for a warm handoff for mental health need. So it is very prevalent right now.
Yeah, and this is kind of just a general comment about on-call providers. Tribal health doesn't have an on-call number. You have to call the tribal dispatch. And sometimes when they have a new person, they're not trained. So they don't know that they're supposed to, if somebody calls with a kid who is suicidal, they call that this has happened. I'm just giving you actually a real example. Mother calls the tribal jail or the dispatch, because that's what they tell her to do. And the dispatch says, I don't know what you're talking about. You've called the wrong number. You think you need to talk to tribal health. So in the meantime, this person doesn't get help. And I would think it would be more helpful for the membership if we had an on-call number, and having a tour of the tribal jail. They are overworked. They are maxed out beyond. And a lot of the calls are from tribal health on call. So it would really alleviate a lot of it takes up a lot of their time to answer those calls. And I think tribal health should have its own on-call number. And then, that number can be widely available to people, widely published. Then they know who to call if they need something after service, after business hours.
Yes, and that's absolutely one of the issues we're hoping to address with bringing in our own on-call, because right now those calls actually go to Western Montana Mental Health. And that's why it's being routed through dispatch, because then dispatch makes that connection. And so with our own on-call, we'll have direct connection with our own on-call providers. And they'll have their phone. Right now, we only have one person. We do have it written as a 2-person position, so they can switch off on call. But what they would be doing is sharing a phone and a phone number.
I was just thinking of a call service. Like when I had a baby, I didn't call my doctor at 2 a.m. I called his answering service and they called him. So I mean, there are medical answering services that do that. And that's what I was thinking, that tribal health should really contract or work with the medical answering service. And then you wouldn't have to worry about who has what number or phone or whatever. Somebody breaks their phone or drops it.
Sure.
Whatever.
Yeah.
Thank you, Councilwoman. That's a great idea. We'll explore that. We've used the 24-hour on-call service before to try to help us manage those calls, but we'll explore that idea about specifically for mental health. I did want to mention a couple of things that Dr. Fox talked about, being telehealth. So we do provide phone cards. If that's one of the access issues, we will provide phone cards to folks who may have trouble keeping a phone active or not. So we do have that service. And then the Heart Fund grant that the governor rolled out several months ago, we've worked with the tribal court system to help staff their position to develop that healing court. So we're engaged with the court system to some degree at this point to catch them before maybe they go to jail and get them diverted early on in that process. So
And so next, I was going to talk a little bit about some of the partnerships that we have currently and some of the projects that we have going with them. And I'll just briefly touch on those. If you have further questions, let me know. But within the tribal health team and CSKT broadly, we're working within the medication assisted treatments team. And so those are the teams that are providing Suboxone and that kind of thing. We, both addictions and mental health, attend those weekly meetings. And so we're able to provide that behavioral health support to the programming that they're doing and with the patients that they're seeing. Currently, the way the MAT team is running, anyone enrolled in the MAT treatment team is required to have either a addictions counselor or a therapist. Most of them have the addiction counselor and sometimes they have both. But that is one way that we support that team. I am a part of the interdisciplinary chronic pain team, and that was put together between myself and Jason Kronbach, the physical therapist for the tribes, and that we have representation from almost all of the tribal department teams. We have pharmacy, medical, obviously mental health and physical therapy. We also have dental and nutrition, diabetes team representation there.
Okay, excuse me, Dr. Fox.
Yes.
Tom has a comment.
Yes.
Go ahead, Tom. Tom, are you there?
Yeah, sorry, I forgot to unmute myself. My bad. Good to see you both. When you brought up Suboxone, that reminded me of a question I had on it a while ago, and so I guess when Suboxone is so important for people in their recovery, and there's so many people that need that. I mean, it is really talking about people, when they're addicted, they have to be. It's a long program of recovery, and sometimes people are just on it for probably indefinitely. So I guess, have you modified anything to improve access to that Suboxone? Because it seems to me like there was a limiting factor that you required people to go to one of our tribal health doctors before they would be part of that. Is that necessary? Because we don't do that for other parts of our program. And it seems to me like we wouldn't want to do anything to delay or make it more complicated to get Suboxone out to the people who need this. That's my big question there.
Yeah, and that's a great question. And I think that has been raised before. Dr. Quorum, our medical director, is the manager of that particular program. And that has been a discussion in our team meetings. And so I'm not sure she may be able to speak to that a little better as to future plans for the MAP programming and how we can increase the accessibility to that program. So I think she might be able to better address that than I would. And Joe may actually have more information on that as well.
No, Mr. Chairman, that's a good point. We're working to making tribal health services as accessible as possible. So if we can figure out ways to eliminate some of those barriers, we'll certainly take that on.
Yeah, I know that just, in the customers that are, the service area that you are, there's lots of folks that struggle with that. And a lot of folks that are paying for that out of their own pocket.
Mm-hmm.
So a lot of that causes a lot of secondary and other effects, chain reactions that are not necessarily beneficial to the entire program or to that person's health or their continued path of recovery. So I just think it'd be one of those easy things to fix and get that out there. So thank you.
Good point.
Thank you. So another program that we're currently working within is the interdisciplinary chronic pain team. We put together an educational series, and this ties into our addictions and issues with opiates very closely, which is why we kind of brought in the medical team and our addictions team to work on this particular issue of individuals who are experiencing chronic pain. And a lot of times chronic pain does come with long-term medications, including opiates. And so helping patients find that balance between the care that they're getting and the prescriptions that they're getting, and continuing to live kind of a fulfilled life, and being able to do the things that they want to do and pursue those valued life goals while living with chronic pain. And so finding that balance. And so we created I think it's about a 3-hour-long educational, multidisciplinary educational program. We've tried many different formats and we haven't had a lot of attendance. We haven't given up on it. I think the shift that we're taking now is we ran a couple virtually broken up into an hour. We tried to break it up into 2 hour-and-a-half long presentations. We then shifted to in-person and did 2 sessions in person in St. Ignatius. We did one in person in Polson and just had really poor attendance. I think over all of those, we maybe had 3 or 4 participants. And so what we decided to do is take this educational program and shift it to a virtual access where people can assess the modules and watch the modules virtually broken down into the different categories that we had, and they can do that on their own time at their own pace. And so that's what we're pursuing on that team right now. At the same time, I did start running a psychology pain group. And so that's the Living Well with Chronic Pain. And that one has had pretty good attendance so far. And again, with the holidays through July, we didn't have great attendance, but we're starting from the beginning on August 1st. And we have a number of people signed up to attend that. So I'm really looking forward to that and addressing an issue that's very prevalent in the community and using the skills that we have on our team to address some of those concerns that our patients have. And with that, we'll still have access to the interdisciplinary chronic pain team. And so if we have questions for pharmacy or medical, they're willing to come into the group and address those questions with the participants who are there. So I'm really looking forward to that. Other program running currently, we've also coordinated with DHRD, currently looking at some of the therapists that they have under their umbrella and hoping to bring some of those services under the wider tribal health, behavioral health umbrella, just to kind of have cross communication with those that are providing direct clinical services to our population. We've been exploring staff wellness and training for our tribal health staff and our broader CSKT staff, recognizing that our staff's mental health and overall well-being is very important. And that's something that, again, there's skills that reside on our behavioral health team that can help address some of that. And so we're working with Patricia Corshane and Patty. We're coming together to address some of those concerns that have arisen on our teams. And then just overall, we're working with I'm not sure if you've been oriented to Journey to Wellness and their efforts to do a crisis response, mobile crisis response. So they are partnering across Lake County to implement mobile crisis response for the reservation and Lake County broadly. And so I've been on their steering committee for about a year now to help with the implementation of that program. And so hopefully that'll be here soon and help address some of these crisis situations that are coming up where it's not just police responding, but they have some supported mental health responding as well. So that's what I have for kind of current programming, if there's any questions about that. And I can also speak to future goals and ventures that we have in mind.
Yes,
Yeah.
Jennifer.
Thank you. Thank you, Vice Chairman. One question that I have is, first of all, I'm a huge supporter of mental health and access to mental health resources. I really think it's the key. And I just think it's so important and really valuable. And I just wanted to ask you if you had thought about if behavioral health and DHRD have thought about like therapeutic homes for children, small therapeutic homes. There are a couple examples of that in Missoula that you're probably more familiar with than I am, but you know, as someone brought up today earlier, for every drug arrest, there's at least one child that is left, and usually multiple. And so I think there's the silent crisis of children being abandoned and children being affected by the opioid crisis and now the fentanyl crisis. And I don't know, I just wanted to know if you have talked about that or thought about that.
Absolutely. There has not been a specific discussion with DHRD around that, but I think that's an incredible idea. And I think that's definitely a need in our community. There's people in my own life that I've seen that could absolutely benefit from something like that. So that's definitely a future direction that we can add into our plans moving forward, is to explore some of that supportive housing.
Yeah, I think that's really important. And there's already a really successful model in Missoula, and they have an office in Ronan. So I think there could be potential for collaboration, but our legacy with boarding schools is not good. But a small therapeutic home that's staffed only by people who have master's degrees in counseling. So it's, you're getting high quality care and in therapy for, being abandoned, being abused, whatever, that's meaningful to prevent children from going, to save them so they go down a better path.
Absolutely.
And my other question was, what are you doing to recruit CSKT members to the mental health field? Because, we have had meetings with the drug court, and there's a huge shortage of LACs in Montana. And, how are we recruiting people to go into that field and to work for tribal health?
Yeah, and I feel like that's a big contributor to our shortage of providers, and some of our vacancies within our therapeutic team is just availability of licensed providers who hold those degrees that we're looking for. And so, I've collaborated with Joe. We've talked about working with SKC and recruiting providers while they're still in school. We're developing programming to support their training when they're having to get hours. So we've had a few people who are working towards LAC who have asked to come work with us to earn hours. A couple of those have not worked out for various reasons, but that is one of the ways we want to help address that, is you can come here, earn your hours in hopes that you will stay once you're licensed. Similarly, with some of the student supported programming that we're doing right now, like I have a partnership with the University of Montana to bring licensed clinical or unlicensed clinical providers who are graduate students to work under our facility. And right now there are no CSKT tribal members currently in any of the training programs that we work with for psychology. And so that's unfortunate. That's the state of that right now. We are doing outreach as much as we can. So for example, this week they're having their Indians into Psychology summer program, which is reaching out to undergraduate students who are interested in a career in mental health. And so I'll be speaking to them this week just to talk about mental health in our facility and how they can build a path towards working with us. The program is directed for psychologists, but it does broadly address mental health. So if someone's coming to that program and decide maybe they want to go LCSW route instead, it's still supportive of that and still helps them develop materials if they want to apply for grad school. And similarly for SKC, I speak at their careers day for undergraduates. So just trying to get the fact that, there are tribal members who do come back and work at tribal health, and that there's those opportunities that are there and that they're good opportunities. We're getting that out as much as we can, and I think we can always do more, especially talking to our youth before they even go off to college, just getting youth interest built in health careers in general to try and work their way back in, which is what I did. So I'm definitely a proponent for that, of kind of growing our own and recruiting them back in and having that interest from a young age.
Okay. All right, we have a comment from Tom.
Yeah, thank you, Vice Chair. Desiree, I think you're a poster child for many things, and they're all good. So I really love your story and your family. I guess for both of you, the one thing that I kind of like this, from this point forward, I would, I'd like to know what we're spending on sending people to treatment. And then, use that as a baseline for, trying to do more inpatient addiction treatment or mental health treatment. So we use as a measuring post if we're successful or not. So it would be, to me, it'd be like, I'd want to see that go down, that cost of sending people away, because we're increasing our services locally and increasing the opportunity locally. So if there's a way you can provide a report for the tribal health department on dollars spent sending people to treatment, that would be a good thing for me to look at, whether it's in a combination of mental health, drug addiction, whatever it might be. I think they're all related. So that would be my request.
Okay. Joe, you want to respond to that?
Yeah, thank you, Mr. Chairman. Included in the packet is a summary of, I guess, current costs. We've used the healthcare services budget that Tribal Council has provided us. So there is a total for FY21 there and year-to-date this year, Mr. Chairman. So if you start at page 50, that's a kind of summary of that report that outlines those costs. I believe these numbers are not exact because it changes daily, but I believe we have supported 33 tribal members to enter into treatment. I believe there are like 15 active members who we're supporting through that treatment program currently. Included in the packet is some information about one of the ARPA budgets, and we had included continued funding for that particular service in that budget. You'll get a chance to see that also in the packet. I think, and maybe to speak to Jennifer's question about how we're supporting, in addition to what Dr. Fox shared, we have also included plans to re-implement what we call the Scholars Program. If you recall, we had supported some students for 3 or 4 years to begin exploring or support them in their career path when they've chosen healthcare fields. Very successful program. If you step back and look, we have pharmacists and doctors and nurses who have all worked through that program, graduated, received their degrees and licensures, and returned to us. So we thought it was important to re-implement that program and start providing those opportunities to young people to begin exploring or supporting their efforts to pursue healthcare fields in the health careers. So
Okay.
also included in one of those budgets is a line item to support that program. So
All right, very good. Any other questions? Martin?
So what's the turnaround time if someone came in to your office today and said, I want to go to treatment, I'm addicted to, let's use fentanyl since that's our hot topic. What's the turnaround time, or what, just walk me through the steps, please.
Yeah, so in speaking with our addictions program manager, I asked that exact question, like what is the projected, what are the steps when someone comes in? And so someone, if they're walking in an office, they could get a face-to-face appointment that day. If they're referred, sometimes it does take a couple days to process that referral and get it in and assigned to someone. Once they've been assigned and connected with a therapist, they're reporting 2 to 3 visits to do the assessment. Our team does a very thorough assessment looking at not only the treatment need, but the overall kind of zoomed out needs of this individual that includes social needs, includes potential follow-up, that kind of thing. And so they do a comprehensive assessment to determine a level of care, and that level of care is based off of the ASAM levels of care, where it determines, do they need outpatient, intensive outpatient, inpatient, inpatient plus detox, that kind of determination. And if it is that level 3.0, which is the inpatient or higher, that's when we begin the process to get them into an inpatient facility. And that's honestly where it varies a lot how long that takes. We have started exploring inpatient facilities outside of Montana. Right now, we frequently use Royal Life Centers out of Washington because their turnaround time is much, much shorter. what happens with our Montana facilities is a lot of our patients are either on Medicaid or since Tribal Health Paid Care pays Medicaid rates, they end up going in the Medicaid wait list. And you may be able to speak to this, but a lot of the inpatient treatment, Tribal Health Paid Care doesn't cover. And so they're relying on other insurance, which is usually Medicaid. And how the inpatient facilities work is they have kind of their wait list and their Medicaid wait list because they can only afford to have so many Medicaid patients in. And so that wait list usually ends up being a lot longer than the typical wait list. We can sometimes get around that by offering to direct pay whatever the normal rate is and not the Medicaid rate. And that's where some of these other funding sources come in. And so I know that's not a direct answer, but that is kind of the process of, kind of referral to when they finally get a bed. If they're not doing inpatient, then they're connected with a therapist and they begin doing follow-up immediately.
Yes, Martin.
Thank you, sir. So I saw, or actually Bing pointed out the detox. Is there a facility or somewhere where we send? Because I mean, that's kind of my disconnect here is like, I know it's a process, but that there's that significant time of when someone, goes in and really wants it, needs it, and then, 3 appointments, it could be weeks, and then either they're back in their old environment or using, or they're detoxing, so they need to use, and then we just kind of lose them. So do we have, where is that facility, or where's the detox thing that's on the list?
The detox that I'm aware of, Royal Life has a detox built into their programming. So they go in, they do their assessment, and then they go into the facility and they do kind of their own mini, what is your needs assessment, but usually they land right with whatever the provider had recommended. And so they do usually a couple days of detox to start, and then they move into the inpatient programming. And some of their programming is designed to step down. So then they go to a more intensive outpatient where they're living in a Royal Life supported facility and then going to day programming and then eventually stepping out to outpatient completely. So the one that we're using most frequently has that detox built in, and that's one of the reasons why is they can kind of go from beginning to end with that facility. But again, that is outside of our state. That's in Washington.
So it's probably just coded different for payment. That's why it broke out. Just the coding, I'm assuming, but.
On this report, yes.
Yeah.
Maybe just a point, Councilman Charles. So anecdotally, not talking about the process, I've seen it happen in as quickly as 2 or 3 days. And part of it, some of this is ongoing while they've made the request for a bed. So while they're waiting for a bed to open, some of this can occur during that same time frame. So sometimes it's a coordination effort. So as quickly as 2 to 3 days, sometimes, like you said, it can take much longer, and you might lose a person because they've kind of gone back into an environment that's not supportive. So.
Yes, Bing.
Yes, Vice Chair. Say, I was looking at this thing that I was pointing out to Martin here. There's not too many teenagers that's listed on that. And that's what we're kind of really concerned about that after hearing about all these drugs that are coming around here now. A lot of these kids that are on them are looking for help, and I know there's facilities over in Spokane that take in these younger kids, and I don't know, but of course, there's always a bed problem, down there. They need a bed to put them in, but is there other places like that around where they can be put in real quick? Because, they're looking for help. A lot of these kids are looking for help, but it's not there at the time that they need it, and I was just wondering if there's facilities there that can take them ASAP.
Yeah, and that has been an identified gap in services for our state as a whole. Right now, I'm a part of a pediatric mental health care in Lake County, where we coordinate with the hospital, Shodair, just interested parties from the county. And that's one of the main points of concern is the lack of resources that we have for youth in the state right now. A lot of our youth who do come through end up doing outpatient programming with our staff. I'm not sure if this just doesn't include, do you know if she included 18 and under for inpatient? So we might have to request those numbers separately and see how many those are. Or if we just haven't had any, which I think is less likely, but I can follow up and see if we have those numbers for 18 and under as well for inpatient placement. But yes, it is a need, as it is with adult, but definitely youth as well.
Okay. Any other questions? Yes, Jennifer.
Yeah, I had another question along the lines of youth. So 33 adults are in treatment right now. How many youth do we have in treatment currently?
That is what I don't have the numbers for. I don't think we have any youth 18 and under inpatient facility right now, but I don't think the number for the past year is 0, as this is reflecting. So I will follow up with our addictions program manager and see if they have those numbers.
So the current number is 33. Is that only because that's all that was available? Is there a waiting list for people to get these kinds of services?
Right now, everyone is currently engaged with a counselor. Whether those counselors are trying to get them into treatment right now, I don't know what that number is. If there's any in progress for inpatient treatment. As of last week, there was not anyone in progress that had not already been addressed and is waiting for a bed. But again, I would have to check with our addictions program manager to see if anyone has started that process since they gave us these numbers.
Just a clarification, it's been 33 total year to date. I believe there are 15 active still. So some have graduated or left against medical advice. Yes, correct.
Okay. Tom, you have a question?
No, but still have my hand up. I'm sorry.
Yep, you sure did.
Oh, my bad.
You're just waving at us.
I am. Let me lower my hand.
Mr. Chairman, were you able to find that document, page 50 on the?
Yeah, I'm sorry, Joe. I didn't, I'm looking at my little tiny phone trying to gather other information. So I hadn't looked at all your information prior to you guys talking. I'm sorry. So thank you.
That's good. If there's more information you want, please let us know.
No, I was really interested in the inpatient addiction treatments and the approvals and how we can do more. Yeah. Thank you.
Okay. Jennifer?
Yeah, and along the lines of behavioral health, has CSKT, Tribal Health, Behavioral Health looked at what it would cost specifically to fund our own treatment center? Because I know there would be grants and I know there could be billing if people are Medicaid eligible or have their own health insurance, part of it would pay for itself, but
Yeah, so I'll jump in on that and Dr. Fox will also, but we haven't looked at the details for that. We do know it would be extremely expensive and there would be a lot of state and federal regulations that we'd have to look at as we walk down that road. I'm not sure if everybody is aware, but I think most of you probably are, there was a resolution signed by Tribal Council a while back to participate with the Rocky Mountain Tribal Leaders Council in the development of a statewide Native treatment center here in Montana. They partnered with the Montana Healthcare Foundation to launch an RFP to bring in a consultant to actually manage the feasibility study and the planning for that statewide treatment center. And one of the things they are going to look at is the needs for adolescents for treatment center versus adults. The RFPs or the proposals in response to that RFP have been submitted. Actually, last Wednesday and Thursday, Dr. Fox and I were in Bozeman reading and rating those proposals. We had two proposals that really kind of bubbled their way to the top. Neither one of them had everything that we were looking for in that particular proposal. We posed a number of questions and the Healthcare Foundation is getting back with those two proposals and asking them for a best and final. So we'll be back in Billings on the 15th, is that right? On the 15th. And I heard today they're actually coming and going to meet with us face to face. So we can really have some good depth conversation with them about their anticipated planning process. I will also say that those planning processes and those proposals are ranging anywhere from 12 to 24 months, and that's just the planning process. Financing and governance amongst all the tribes in that implementation process for the treatment center is all part of things they're going to look at and they're going to work on and make some recommendations. Overall, what we're hearing at the point to have a treatment center really ready, open and ready to take in patients is probably anywhere from 4.5 to 5 years away. So that's what we're looking at as with that treatment center comes to fruition here in the state of Montana. It's exciting that it's coming, but it's a complicated process and it's going to take a while. We're also not really sure how many beds each tribe is going to have. It may be dependent on how much money each tribe puts in. We're not really sure. That's part of the planning process and what will be decided by the tribal leaders as we move forward with that. I'll also say, so I want to ask Dr. Fox, is there anything more you want to add about that?
I think that was pretty thorough. Early conversations, we did talk about 2 regional treatment centers and if it's feasible to maintain 2 centers. And the other conversational piece that comes in is where these are going to be placed. And I think that's a big factor for our community, you know, if they're all over in Eastern Montana, facilitating transportation and just community connection. If it ends up being one of these kind of really rich step down programs, are they stepping down into a community that is not their own? And I think that's a concern for all of the tribes involved. And so I think that is part of whoever we have helping with this planning is to help facilitate those discussions and make decisions around what is going to work best for all state of Montana tribes, as well as feeling like individual tribal needs are met.
And then I'll just add on that, Vice Chairman Two Teeth, I know that you know the conversation has been having those centers in Great Falls and Billings. Having it on this side of the mountains has really not been, at least what we've heard, kind of bubbled to the top. But the planning process will really kind of outline what those recommendations will end up being.
Yeah, still a lot of questions.
Yeah, a lot of questions yet and a process ahead of us as we begin to see what those centers or center ends up looking like. I think the other discussion is that I know that Joe and Dr. Fox and I have had is really looking at a process that perhaps internally here on CSKT that we could implement that really prepares us for what's to come in a treatment center, whether or not it's focusing on getting people ready to go to treatment or aftercare when they come home, whatever that is. Some of those pieces that don't exist and probably won't exist in the new treatment center because it's really going to be focused on initial treatment. So I think there's a whole process ahead of us to really think about how we can get more robust around these issues here for our own tribal members, because we know that the need exists. But we don't know what the answers are yet.
Yeah, I like that you're thinking about a pre-center, like a pre-something, a holding place. So if somebody walks into the defender's office or to tribal health and says they want treatment, then they're ready. Someone without a phone, without a home, so they just don't get lost. So they can go somewhere immediately while they wait, however long that is, 2 to 3 days or a couple weeks or whatever. So then they're just at least safe for that moment, and then, you know, they can go where they need to go safely.
Yes, Joe.
Yeah. So later in the presentation, we've created that task kind of in our work plan as a placeholder. I think, like Patty said, there's a kind of a lot of definition we add to that, but we have created that as a task for us going forward in both 22, balance of 22 and 23. So add some definition to that, but it is included in our task list or work program. So Dr. Fox had something to add in addition.
Yeah, and so I'm really glad we're kind of going down this road because it leads into the future goals that we have for the program. And so part of that is the American Indian Health Leaders Regional Treatment Center plan that we're participating in actively right now and hoping that that goes in a positive direction. And also looking at what we can do now with the resources that we have now and what we can grow into reasonably and feasibly with, again, the resources and the staff that we have, and in hopes of growing our staff so we can provide more comprehensive services. One of the projects that we're currently working on is a proposal for a tier 2 for THIP. And so I would coordinated with the community health and tribal care coordinators with tribal health to start expanding some of our addiction services that we have. And we decided the direction to go is kind of expand under the umbrella of peer support and build a peer support program. And as a part of that, bringing on additional licensed therapists who can do work with families, who have experience with doing family and couples work, who also have experience working within addictions within families. We feel like that's extremely important in an area that doesn't really get focused upon particularly in inpatient treatment. Usually it's, we always refer to it as recovery in a bubble, because you go off, you start your recovery process, you're removed from the elements that are causing you to get involved in substances in the first place. And that's necessary for a lot of people. And it's a really great structure. And at the same time, then when they're released into step down programming or into outpatient programming, they're landing back into the same circumstances that brought them into that addiction in the first place. And so addressing within the family, if the family themselves are struggling with addictions, helping support the family, helping them support the person who's involved in care, really just having more wraparound services on working with the system and not just the individual, because we know that's not going to be the most effective. And so we're in the application process, I believe, for that. I think, has it been submitted?
No.
Okay. Okay, so we're in the drafting and finalizing the draft of that proposal now. So we're hoping that's a direction that we can go in pairing with other tribal health support. But if for some reason we don't get that, that is still on our list of goals, is to bring in more family and addiction related treatment so we can do a lot more groups, a lot more family oriented recovery.
Any other questions, comments? All right, very good.
If I can just add one more thing. Councilwoman Finley, I certainly want to thank you for bringing out the idea of therapeutic homes for children. One of the things I'm not sure if Ruth remarked at, but the social services budget has The request is much larger than previously, and primarily because the number of referrals that they're receiving is up by 400%
Wow.
for youth, and 98% of those referrals are due to use of drugs in those homes. And so it's really becoming a huge issue. There's a lot of partnership beginning to happen with tribal health. Dr. Fox is a wonderful resource and knowledge that we really have to kind of build this comprehensive system that brings different departments together to really wrap our arms around our children and our families moving forward. So I just have to thank you for bringing that up and also letting you know that's why the social services budget has such an increase in it this year.
Thank you. I really appreciate that. And, you know, I was just reading up on it recently, and there's a really good model in Missoula. And, you know, I think it's actually a house. It's not an industrial facility. It's a home staffed 24/7 with no more than 6 kids. So potentially there could be something like that in every town on the reservation. And I think there would be a need for it. So kids can get not just a safe place to live, but therapy. They can get help and intervention before they go down a path that that's going to be hard to get out of, just to prevent it in the first place. And Craig said that today too. The best thing we can do is prevention. Prevention is the key. Thank you.
Mr. Vice Chair, that concludes behavioral health presentation. We could include additional conversations around behavioral health and substance abuse as we schedule an orientation, but that's later on in our agenda about scheduling an orientation for the entire department.
Yeah, that's an issue that could be discussed all day.
Yeah.
Just because that centers around a lot of the problems that we're dealing with on a daily basis. So Dr. Fox, thank you for the information and like I said before, we're very fortunate that we have you working on things like this, and because mental health is very challenging, and it's because there's so many perspectives from it that I'm just glad that we have you all on our staff. So thank you.
Thank you. And thank you all for your comments and ideas. It's definitely giving us directions to grow in our goals.
Very good.
She's a star. We're lucky to have her.
All right.
So the next section, Mr. Vice Chair, is maybe about structure. You know, what information do you want from the department at these health committee meetings? How do we provide you information to measure performance and health status of our community? So I've put some initial information together, beginning on page 51. Based on information that you see before you in regular council meetings, the resolutions I've put together kind of an overall task or goals list for FY22 and FY23. This is where you can let us know if we're on track, if there's things we need to add, if there's things on this list that need a lower priority and we need to focus our efforts elsewhere. So that's what this does. If this kind of meets your expectations and your priorities at this point, we'll start putting the meat to these particular plans going forward.
Okay.
If there's some changes or edits or things we should add, this is the opportunity for you to maybe provide some direction to us. So that's the goals. On page 52, I'm trying to give you some data to measure department performance and then impact on community. So the first section are what I identified as performance measures. You know, for example, 1,554 community members have chosen one of our providers as their primary care provider. Theoretically, if we want to improve performance and that's a priority, then you can measure how effective we're getting more people to choose us as their primary care provider. I don't know if that falls in line with what you're doing, but certainly that's my goal is as you know, many members of our community choose primary care outside of our facility. We want to provide a level of service and accessibility to attract them back so they choose us. We want them coming to our healthcare to receive healthcare from us. So one of the measures is how many are choosing us as their primary care provider. So if we do things well, then you should see that number start to change. So that's a performance measure in effect. Total clinic encounters, that's again, a measure to determine how effective we are or how well we're performing in our community. That was the primary focus of those performance measures to figure out how well we're doing the work and attracting clients. The second portion of that is trying to measure the impact we're having on our community. It's hard to do it individually, but there are some measures in IHS, in the RPMS system. They were called GIPRA measures, but these are just measures to make sure we're providing good care to our community.
Joe, the level of care is so tough to measure, individually, because everybody has their different experience going into tribal health or dealing with one of our primary care providers. Some people have really great experiences, others refuse to go back, but we don't know that. We don't know that unless they come and tell us as elected leaders how they were treated, and we can't base the performance of care that was given based on that, because it just, a lot of it's just based on circumstance at the time. So anyway, that'll be another challenging issue to try to address when we evaluate.
Yeah. And hopefully, I guess a reflection of that level of care will be that our numbers start to get better.
Yes,
Our numbers go
exactly.
increase, so people
We got to start somewhere.
yeah, hearing we're doing better, that they get good care, they have good access. So theoretically, the numbers will start to change as far as how many people choose us for primary care. So those are my first drafts. If there are other measures you think are important, please share them. We'll try to figure out how to capture that in our databases. As you know, we have a number of different databases in tribal health. We're trying to resolve or figure out how they communicate. Epic, Pioneer, Daphne, we're trying to figure out how best to consolidate that into Epic, or have those databases communicate so we can share that data across.
Yeah, Len, I got one.
Oh, yes, Tom.
Yeah, and Joe, I really appreciate you put the primary care list. That's really important. You've got what there, 1,500 people. That is a real important number. And we'd want to have that is it going up? Because that is your funding base. But the thing that always kind of bothered me since I don't know, since maybe Kevin was there, was if we're sitting on a bunch of money, that means people are being denied healthcare. So if there's a big balance there somewhere, I know later on in your document, there's something with 8 point some million in it, 70% expended, or 70% remaining, I think, with based on the number of months left, they're sitting on quite a bit of money there. To me, that means somebody's not getting cared for, and certainly you'd want to be able to say that there's a reserve somewhere. But if we're sitting on money, that means to me where somebody's not getting healthcare they could get. So I don't know if that's a measurable item you'd want to list or not, but to me, it's a key indicator that people aren't doing their jobs, or we could do a better job expending that to provide services to people.
Yes, Joe.
That's a good point, Mr. Chairman. So that's the Tribal Health Paid Care Program. That's those services we pay for outside of our clinics. And you're right, there is a significant carryover from year to year. We are currently in the process of trying to expand services that will be eligible for that care. So we want to do a better job of using that resource to pay for care. Mr. Chairman, you're correct. Some things we don't pay for that we're exploring now is dental care. Because we provide dental care as a primary care service, our focus is trying to get people into our clinics, but there's a higher level of dental care we can't provide that we want to include as in our scope of services that we will pay for outside of us. So we're working through those contracts now. Just an interesting process to try to contract with an orthodontist or a high level of care. So we're trying to set those up and create the best access and I guess get some fair pricing for those services. A good point, Tom. We'll try to include a measure of that, how well we're utilizing that resource from period to period.
Yes, Jennifer.
Thank you. So I have a couple things. One thing I would like to see happen is if tribal health could pay for more cosmetic dental care. So if somebody's missing a tooth, I mean, it's not life or death, but it has such an impact on people's self-esteem and their employability if they can get those things fixed for free at tribal health, or braces for kids even, you know, if somebody has really, you know, a high need for that and their parents can't pay for it. I just think that would be wonderful if tribal health could at least help offset the cost for that. And my other thing was, has tribal health looked at providing things like alternative medicine, like a chiropractor or an on-staff naturopath? So if somebody wants to access alternative medicine and they don't, you know, they don't necessarily want to go to a Western medical doctor and they might feel comfortable going to a naturopath, or if they need a chiropractor, is there a possibility that tribal health could have have their own chiropractor on staff?
So we do currently pay for that service if they get a referral from their primary care doctor. Again, that healthcare services budget that you provided us the last couple of years, we use that as a resource to pay for that care. We have, and I don't know if it's the best model or not, but we have required that the community members go through a tribal health primary care doctor to get that referral. Trying to find a balance of how to manage the resource, but make the service available. I think bringing one of those, like a chiropractor on staff, makes sense from the business perspective. And I'm a biased that way, but we can bill for those services if we bring a chiropractor in-house and make it available to as a direct care service. So I don't know if I answered your question, but one, we do pay for that service if we get a referral.
Joe, could I ask one question in regard to that? Because you mentioned that they could get that if they, I think only if they go through one of your staff doctors. Is that something that's necessary? Do you have to complicate things that way? I mean, why is that? I mean, why would you want to restrict yourself to that particular topic like that?
Sure. Good question. That was a pilot project we rolled out, I believe, 1 year ago or 2 years ago. Again, we just didn't know what the demand would be, so we wanted to get some sense of how much money would be spent out of that. Certainly, we can change that program or expand that program to include all primary care. Essentially, what would be happening is 2/3 of the patient care would be eligible to use that budget to get primary care outside of us. I just don't know what the balance is. Certainly, we could take that on and figure out, you know, how much might be utilized out of that particular budget. I don't know if that answered your question, Mr. Chairman, but as the pilot, that's how we tried to manage it and get a sense of how much demand there was.
Okay, Martin.
And just kind of when we started talking about dental, kind of building off what Jen said, the other thing would be like crowns and bridges and stuff. A lot of people don't get those things because it's cost prohibitive. $180, to do one, that's kind of a lot for most of our tribal members. And so then they don't get a crown. So then they have a tooth that's, had a root canal on it. And then they eventually lose that tooth because, versus helping out our membership. I think Len mentioned that when he went through that, it's a burden to a lot of people. And I understand, I don't understand, I guess.
Any other comments, questions? Yes, Jennifer.
So in terms of increased access to care and encouraging more people to choose tribal health as their primary, I think it would be helpful for tribal health to have better hours, be open later, at least one day a week. So people don't have to choose between taking time off work and going to a doctor's appointment, or having a kid miss school or something like that, or having a clinic that's open on Saturdays. And I think, Tom, if you want to talk more about your pharmacy idea, but I just think increased hours would be necessary.
Oh, yeah, sure, Jen. I think Patty's heard me say it many times, Rick, that I don't know, it seems like an opportunity not only for, increased service to our membership and for the overall tribal health customer, but also the community at large is, a 24-hour pharmacy that people knew that was there. There isn't one that I know of on the reservation. So that kind of a service is going to bestow a lot of respect and a lot of increased interest in tribal health. So yeah, I just like the idea of having be able to expand that to everybody, that the pharmacy would be open to the entire public. It was open 24 hours a day and those off hours at least. Maybe there's an opportunity there for added revenue generation. But I wanted to get back to the dental too, that, one of the things, Joe, that when you talk about dental, so I paid for most of my mouth out of my own pocket, but because I don't have insurance for that particular item. And, in tribal health, the program up in Polson's been excellent to me. And I can't say that I had one bad encounter up there. And they've really worked, Dr. Pitts has worked with me quite a bit and the other doctors up there. But when you talk about self-esteem in our work, you talk about so many of our tribal members that, part of customer service and part of being, your self-esteem is having a good smile. And to think that we can't, we pull teeth, we don't try to do that kind of stuff where we're putting caps on, or we're taking care of bridges, or we're doing things like that for our membership. They're what a lot of the country thinks is just basic dental care. I would just love to see us be able to expand into that, because I would sit at my office when I was at the Fish and Wildlife, and you want to have folks there that are working for me and only have a half a set of teeth, and I don't know why. I honest to God don't know why that is. Why can't we fix that? Because it's so part of their being able to work, and I'm not saying it's not a shallow thing. I think people really want to take pride in their appearance, and they want to have a healthy mouth. And so I think that's one of the basic self-esteem things, one of the hierarchy things, is to have a healthy mouth. And so I really endorse and support any increase in service to dental program, because I think it's a win-win-win in so many ways. So I just wanted to make sure I brought that up. One of the other things I wanted to bring up was this goes to me having my own health care, and I challenged everybody. I wish every tribal member had what I have, so that they at least have that coverage. Other than, of course, they don't have dental, and they don't have optical. I guess I pay for that out of my own pocket. But one of the things, if I'm spending the money and you're spending the money, Joe, paying a premium for insurance. And I remember when back in the day when Bird said, "Hey, we're gonna do insurance for our employees. We're gonna try just to help be a benefit to the overall public health budget. You know, we're gonna provide some insurance and help do this." And so I would think at some point in time that if I have an employee that's spending money on healthcare coverage and they're meeting us, you know, halfway or whatever, that we would always pay that deductible or that copay for those people. That it would just be automatic. Why would there be any challenge to that at all? When these people are paying for it out of their own pocket, help pay the premium for it. So I just really think that that's an important thing. And when I challenge about insurance, I remember back in the day, I think when Teresa was working, and there would be some catastrophic health thing, and it was cheaper to buy insurance for that person rather than to have the tribal health budget or Indian Health Service budget be forced with millions of dollars on one particular issue. It was easier to just buy insurance for that person. So if it's feasible and it's doable to do that for some expensive item, why isn't it feasible and doable for low cost coverage, like say dental program for everybody? Those are kind of the challenges that I'm always struggling with on how can we provide the most to our people. And is that the bench? Is that the bench to compare your overall department performance, the true bench? Is it, are you providing better service than someone on private health care? Are you providing the best we can and more efficient? And is it customized, bringing in our own unique cultural values that we can't get on the outside? So I think those are my big things that I just wanted to make sure I brought up before the COVID takes me over here again. Sorry, I just got a heat flash. Yeah,
Hang in there, Tom.
yeah, I'm trying.
Joe?
Yeah, Mr. Chairman, I think that's an excellent idea. I think as far as the dental program, in large part, I think it's a carryover from what I just managed the program. And I think one of the primary reasons why we compacted the program is we could establish those criteria and those services we want to pay for. I don't know why we can't explore that, expanding the dental services specifically to those issues you mentioned, Jennifer and Tom. Yeah, we can take that on and figure out how we expand that.
Well, I know when I was going through that bout with all of my root canals and everything, I had an opportunity to visit with Dr. Pitts, and he explained to me the expansion plan that they have and that they've been discussing for some time, and how that would impact all of the services, especially mainly Polson, and how we would be able to increase capacity and potentially get the emergency program back in place again. So it's really complex. He kind of went into detail with me, and it's like, wow, you guys got some tough decisions to make, but at least I had a better understanding of what needs to happen. And so anyway, did you have another comment?
Thank you, Vice Chair. Another question I wanted to ask is about prenatal care. And, you know, if tribal member women have access to things like doulas and other services that would increase the outcome of a healthy birth and a healthy pregnancy, and some, you know, aftercare. And, you know, if there's some mechanism in place to help tribal women have healthy babies, I think that's really important. And I don't know what's currently in place or if there's things that could be done for that. But I would love it if tribal health could pay for, you know, a doula service or some postpartum care that's lacking for so many women. Then they go home and then they don't have no one checks up on them, you know. And I think it's also a mental health issue with postpartum depression to have somebody physically check up on a woman as a protocol a week after they have their baby, you know, just to make sure that we're having healthy babies in our community.
That's a good point, Councilwoman Finley. that has been part of the discussion about the focus of the Ronan Health Center as we begin planning for that opening. Should it be women and children focused? Is that the focus of that particular health center? It is a gap. We don't particularly provide a good service to that. And that's how we maybe lose community members, because we don't provide that specific care for women and children. So that's part of the discussions about how we stand up and focus that Ronan Health Center going forward.
An education class for pregnant women, a childbirth education class that's tribal specific. And it's been a long time since I've had a baby, but I still remember that. There's just not any resources specifically for tribal women. And I mean, I just personally accessed some resources in Missoula and I didn't feel comfortable there. I was the only tribal woman and I only went to one thing and it just wasn't for me. But I think something that's local and tribal specific would be necessary to help women, especially first-time mothers, and definitely postpartum.
Yeah. We can take that on now. We don't have to wait for the Ronan Health Center. I think we can task that with maybe the Public Health or Community Health Division to put something together.
Any other comments, questions? Okay, yes, Jennifer.
So I had one more question about the idea of case managers for tribal health, because I know that I don't remember the exact statistic, but I know a small number of people use a lot of resources. And there are some people who don't use a lot of resources. And, I would think, the idea, how would that work have you guys thought about that? If there's some idea of some way to do a case management system, if people wanted to, or if they would be assigned to a case manager to help them make sure they get to all of their appointments and to help sort of manage their care if they have a lot of complicated care going on, to help them navigate through the system. Because if you're on lots of meds and you have lots of different kinds of doctors, plus you need behavioral health, it gets really complicated. And then if they're sick, they're vulnerable, they're tired. It's hard for a well person to navigate all of that, much less someone who has a high level of need.
Yes, so the Tribal Coordinated Care Division has case managers help clients with that specific issue. So they do help them schedule appointments, get appointments, follow-up appointments, contact other providers, help them access or refer them to other resources within the tribal or local structure. So yeah, they are very active in working with that particular age group. We'll get a chance to explain that program when we do the orientation, or we can get you a summary of the program here in the next couple of days. We'll get you something to you about the Tribal Coordinated Care Division. Yeah.
Very good.
So measures. So that was just a discussion and hopefully some direction on what measures are that we should include that are not on here, or if there's something that's not a priority for you, we can certainly edit this to reflect information you want going forward.
Just one question, Joe, sorry. Where would I find that information on the number of deductibles or co-pays that you're doing for people with insurance?
It's spread out. So the Tribal Health Paid Care Program pays some of those costs, and you might be familiar with the process. So after a claim is submitted and primary insurance has paid, then those deductible or co-pays can come back to us, but it's a lengthy process. You had a medical bill to navigate. You might be familiar with that process. So tribal coordinated care, or tribal paid care pays some of that. We also use the deferred services budget to pay for some of those as they come to our attention. So in a couple of different places, Tom, to figure out how we might provide you that information. Yeah, so those are the two primary resources. I'm trying to think of how they come to.
Well, I guess, Joe, what I'm after is that how many are you denying and how many are you approving? If there are being denied, I'm kind of interested in that more than anything, is why, or what are those unique circumstances, or why someone with insurance, we wouldn't cover the copay or the deductible.
Okay, I think I understand the question now.
To me, that's something that, it would be a real improvement. I mean, it just because it seems like to me, it's unnecessary conflict. That's the way I look at it. So for the customer who might be the tribal member with insurance and needs a deductible being paid by tribal health or a copay or something, there's a little piece left, but doesn't get covered by their insurance, and why wouldn't we pay it, I guess?
Yeah, let me get some answers for you, Mr. Chairman.
Okay, thanks, Joe.
It seems like those are the claims that end up here often, and they've gone to collections by the time you see them. So you're right. We've got to figure out a way to get in front of those before they end up in collections.
Yeah, Joe, I know we had that discussion last week with the tribal leaders. That was our discussion with IHS on how they would formulate a process to work with the tribe specifically to find out how many of those tribal members' medical bills went to collections, and so they can start looking at formulas to adding that to the IHS budget and cover those bills. So anyway, that's coming down the line, just FYI.
Okay, any additions, any additional information you want on the performance measures or health status measures? I think what's important, what will be important is for you to see this information from period to period.
Yeah, and as we go on, I'm sure there's going to be some of us up here that'll have more input on what type of measures. But I know Councilwoman Matt had some concerns about how those were going to be addressed, and so hopefully that she'll be able to join us at the next meeting.
Sure. The goal is to improve on these measures from period to period, so you can visually see our progress. Then I'll move on to the next item. On page 53 is the dashboard report. You may be familiar with this particular format. It's something Patty shared with us early on in her tenure, and we were able to share it with the division directors in tribal health to talk about the balance of FY22 and try to implement this particular reporting tool as part of our operations and reporting to you and the executive team on our tasks and progress on them.
Can I just talk about the board for just one quick moment? So I've been in several council meetings and continue have heard the question that, sometimes we're not really sure what the departments are doing. And I wanted to create something that gave you a quick glance at what are the goals or the outcomes within the divisions of that report, and then how are they progressing towards actually meeting those outcomes set in the goals. So are they a quarter ways through? Are they, as you see, the 26 to 50% through? Are they 3/4 through? Or have they met that goal for that particular fiscal year. So this is a new form. I've rolled it out to all my 7 departments, and we're going to start to structure it and use it and roll it to you. Probably quarterly or biannually, but that way we call it a dashboard. So in a really quick instance, you can look and see how they're progressing towards the outcome listed in that goal or objective, rather than giving you a big 15, 20, 30-page report to read.
All right.
And that's why we call it a dashboard. So Joe's the first one to really kind of structure it and have it ready for you.
All right.
Thank you,
Patty.
Joe.
Just a note, so this was updated this morning as I got additional information. So the one in the packet has blanks in the behavioral health and the public health. Those are filled in the follow-up email we sent. So there is an updated form for that. Again, something we can work with from period to period to measure progress, or gives us an opportunity to share some comments or challenges we might have faced kind of implementing those goals.
All right, very good.
Next, I've included a broad brush of the tribal health organizational structure, kind of a work in progress. I have began those discussions with Patty about how we structure the organization to provide better services and be more responsive. In its current structure, it's difficult. It's complicated. It's a large organization. I'm trying to figure out how to align components within the department to be more focused and be more accountable and just be more responsive, I guess would be the best words I could use. So this is an early draft. Essentially what I'm trying to do in this particular draft is provide all the patient care under one supervisor. So I would have someone who's responsible for that, and I could go to address any patient care items. I also have a division that I'm calling patient support. So there are a number of services that are not direct patient care, but they provide supportive services to patients that are not provider driven. So under that, the patient travel function, the insurance support, help people identify and sign up for insurances, patient registration. So by function rather than how we're structured and how, I guess is the best way to describe it. And then this administrative branch to take care of kind of the administrative duties. I'm often asking my division directors to provide a lot of administrative support, report writing, responding. So I just want to create a different structure to maybe better serve the community. This is my early draft and some work to do as we build onto it, but broadly, this is the organization structure defined.
Okay. Any questions on that? Okay, moving right along.
So next would be kind of just a short list of large projects that we've kind of got on our plate. This in conjunction with kind of the work plan goals is just kind of the larger projects we've got to address with all the day-to-day stuff. I just wanted to get that for you. Again, if there's tasks you want added to this, if there's a particular priority you want us to address these in, just let us know and we'll make those adjustments. Next item, I think I've tried to create a single format to address all of those issues on a financial report. So this is a list, Excel spreadsheet of, I would say, all of our funding sources, but I didn't get them all. There's a Montana Healthcare Foundation grant for $1,000. So and we're getting funding, new funding sources all the time. So as of the date, this was accurate, but it's changed. And what it identifies is the initial budget, year-to-date expenditures, balance of those particular funds, and balance as a percentage, and then the person responsible for managing those particular funding sources. This is just a compilation from the accounting package that the tribes have. We just pull those reports. Martin, you might be familiar with them. They're those cert reports. We use that data to build this particular. We're trying to create a summary all in one glance. So that's the financial report through June 30. The next page, page 62, is our primary funding sources, our reoccurring funding sources that Patty asked me to identify. If we've identified a potential carryover, or if we're going to have a plan to spend the balance of those funds, using those resources annually that are provided to provide care. What's our plan to get those deployed the balance of this fiscal year? So I tried to create some notes on some of those larger funding sources about how we plan to utilize the balance of those funds for the fiscal year they were provided. ARPA's an odd one, but it's just a significant resource that we need to put some plans together to utilize those resources. And the following 2 pages are specific to ARPA, and I'll transition to those. Any questions on the financial report before I move on? So page 63 is a proposed budget for account 4191, ARPA lost revenue. A portion of that fund has been used to support the Ronan Health Center construction. I believe that the total cost of the center exceeded the resources provided by the state. So some of those funds will be used to cover that gap. I've identified some other potential uses. Again, you can provide direction if there's other priorities you want to focus those resources on. But I've identified other uses, potential uses of those funds to utilize those particular resources for those projects. I'm trying to figure out which ones might be important. In addition to construction, I think we've also included in a budget to purchase the medical equipment. IHS is to provide some resources if there's a difference between what IHS provides for medical equipment. We had proposed to include that in this particular budget. This particular budget, we had proposed it would support the student scholars program again going forward. I did include, I guess, an assessment and recommendations on the elders care program. How do I frame this, Patty? So I think Patty has asked if we could consider, is that the right word, how we might improve the elder care services that we offer now and maybe transition it to tribal health. Is that fair?
Yeah, so we're having a conversation that has been ongoing with Joe and Patricia Corshane about elder services and what happens. And are there some pieces of elder care service, especially those medical pieces, that make more sense to live under tribal health? So those are conversations that we're having and really doing some feasibility about what that structure looks like. Is there better support under tribal health because of the nurses that already exist along with the training system that exists? And at the same time, we'll be looking at the state regulations and making sure that we can provide the direct level of care to our elders as we move forward. So there may be some recommendations for restructure there, but we're really being thoughtful about how we move forward and recommend reorganizing.
All right, thank you for that, Patricia. I know in the past, we've had long discussions about that transition and the reasoning why we continue to keep elder program in the social services. Man, we had some tough decisions to make because we've had elders making specific requests on people that they wanted to provide care to them. A lot of them were just family members. And many of them would not be able to pass the background check, you know, and it was decisions like that that we were contending with at the time. And so it's good to hear that we're looking at doing some changes here, because this current program is just such a huge liability to the tribes as it exists right now today. And you know, all transitions have change. Change is scary to a lot of people, so we're just gonna see how that plays out, but I appreciate you guys having that discussion and seeing how we can move forward on that. So, thank you.
Thank you, Mr. Vice Chair. And then the second budget, again, potential use of the ARPA behavioral health budget. We have nearly expended the healthcare services budget you have provided for us. We plan to continue to support inpatient care as needed. And we had identified this as a resource to continue to support that care going forward. Understanding it's a short-term solution, and included some dollars in there to perform an assessment and recommendations on how we address the level of care for the inpatient or the substance abuse as we define that. So similar, but not to the Rocky Mountain Tribal Leaders effort, but specific to CSKT.
Yes, Bing.
Thank you, Mr. Vice Chair. Joe, I was looking at this budget request form here, and I see a lot of housing for the medical students and whatnot on here. But on the bottom where the elder care community assessment recommendations are for 250,000. Is there any possibility that we could use some of this for our elders for housing? I know it's pretty hard for our department over here to help all of our elders with housing issues, but I know we have some elders with medical issues. You know, I'm working. I have one individual. He's kind of latched on. I mean, I know every time I turn around, he's calling me. But I think Patty knows what I'm talking about. But you know, he only has one leg. Lives in his car all year long in the wintertime. We tried. I told Patty the other day. I talked to him about times where you maybe looking for a place to live for the winter. And he has a home over in Hot Springs, but it's really unlivable. And there's taxes against it. And he can't move in there because town has, you know, taxes against it, and he can't stay there anymore. Water and everything else behind. So he can't stay there anymore, but he doesn't want to get rid of that place. But I don't think down the road, there's not going to be any question where the town is going to take it over or something. But he does need help, you know, and I've been trying to help, and I know a couple other council members here try to help him. But he's a type of individual that, I don't know, I just hate to say it, but he's bullheaded, you know, but, and he just doesn't want to have that, kind of help, you know, unless he kind of initiates it. If you don't, he doesn't initiate it, then why didn't you come and talk to me first before this happened? And that's what happened with a couple of Christians, people that went and seen him, you know, gets mad about it. But people like that needs help, you know, these kind of help with places to live. You know, we've been trying to get these people off the street, get them a place to live, find some place for them to go in the wintertime or whatnot. But this guy's 33 years, the past 3 years, that's where he lived in his car. You know, and I told him the other day, I said, you know, it's about that time we start looking for you a place to live. It's getting close to being snow flying here again in a few more months. You know, and I don't want to have to stay in your car again this winter. Because last year he kind of got a little bit of frostbite, I guess, on his feet, but you know, he said he was kind of bothered with it, but he's already lost one foot, you know, and then he just the other way, if he keeps messing around, he's going to lose the other ones. You know, it's going to frostbite, and next thing you know, he's going to have problems and he's going to lose it. You know, and like I say, that's where he lives, in his car every day. You know, I mean, he's there every day, and it's just, I feel sorry for him, you know, but I don't know what to do for him anymore. You know, he calls me and tells me what he needs. I pick up parts for him in Missoula. I do about everything he asks me to do, you know, help him with a little bit of gas money and whatnot, but it's just something that, you know, that he just stubborn. No, he doesn't want to burden anybody, you know. That's just his problem. But I like I say, I feel sorry for him, and winter's coming on, you know, and I hate to see him stay in that car again all winter long, you know. I try to see if we can get him into that place in RLE up there, but he just didn't want to comply and do what he had to do to go to see if he could get in there. I did bring him a elders application to get updated here last week. But I don't know whether he got it in or not, but I did bring him an application so he could get updated for the elders program. But I don't know what we can do, but I would just, you know, be nice to have a place where some people like that could go.
Thank you, Bing. That might, I mean, this particular resource, we might explore with a homelessness committee. It might be something we could support that effort going forward. We can certainly add that to the goals, yeah.
Any other comments? Okay, moving right along.
That was the balance of my materials, Mr. Vice Chair. Again, if there's a format that better serves, you know, the information you want, or the format is something different, just let us know and we'll make those adjustments.
I'm sure we're gonna be modifying it as we go along, Joe. You know, because as we get different council people more involved, we didn't have the full council today, and I know there were some that were interested or anticipating the next tribal health meeting, so we'll get that changed. And yes, Patty.
Yeah, so just in addition to what Joe said, so if this type of agenda works for you, if you want to see any changes to it, but I think our other question is, how often do you want the health committee to meet? So when you look at that last page of the ordinance, It just really establishes the health committee, but it doesn't really have any structure for how often we would meet. So
That's a
we'd
good
be looking
point.
for that guidance from you.
That's a good point. I mean, the last time we were meeting, I believe it was once a month, wasn't it, Joe? Once a month. I'm still good with that. I don't know how the other council believes. Mike? Once a month? Bing? Martin? Tom?
Yeah, I think once a month. I just wanted to bring up one thing before I forget, and it's related to this morning, Joe and Patty. So I know they're the community health program services. We're talking about fentanyl and the youth and everything. And so, you know, I know that I think you guys have some COVID billboards up, things like that, but I really think that if there was a really strong effort put forward by community health branch to, you know, put up anti-fentanyl information on signs, and, you know, remember the initiative the rich guy did for meth? Had all the billboards, and he just put forward his own money for a major educational campaign. And I think that would be beneficial for us right at this point in time with our youth and the absolutely gigantic fentanyl, I don't know what you want to call it, disaster that's happening right now. So if that's a possibility for more of your staff, Joe, to go hit the schools, hit the youth, have a real strong, you know, fentanyl pill's a death pill, you know, whatever it is, just really get out there and work it. I think we're missing that right now, and that might be something that would help us quite a bit. So yeah, I'll take those COVID billboards and put fentanyl on there, and, you know, whatever, you know, do something. But that's just a suggestion for your community health staff.
All right. It's a good point, Tom. Thank you. Jennifer?
Just one last thing. Thank you all for coming in, and thank you for the good work that you do. And I will be having a district meeting in August. And I'm going to do my district meetings a little bit differently. I won't be having people do presentations, but I would love it, Joe, if you could come and someone from paid care just to be there to answer questions. So I want it to be a place where people can do most of the talking and ask questions. And there's always so many questions about tribal health. And so I'll be doing my district meeting on a Friday morning, and I'll be providing breakfast. So I'm just in the process of setting up a time and a place, but I would love it if you and someone from paid care could come, because there's always so many questions about that.
Absolutely.
Thank you.
Absolutely.
Breakfast, huh? All right.
There's a lot of ground to cover through tribal health. I mean, just a big program.
Yes, it is.
If division specific or topic specific is more productive for you, let us know if that's an approach you want to take. If we're going to meet once a month.
Okay. All right, well, Joe, thank you for today's presentation, and thank you, Dr. Fox, Patricia. Very much appreciative of you all because of the services you provide to the people. And I know you guys have very difficult jobs to do, and we're very fortunate to have you. Yes, Patty.
I just have one more thing that I want to say. I think Joe touched on it at the very beginning about if you feel it would be helpful for a full orientation to tribal health services, or if you'd like to see him bring in perhaps a different division to each one of the health committee meetings. So I think that guidance for Joe would be helpful.
I would.
Because we want you to understand more about tribal health.
Exactly. I know it's hard to get the council together all together at one time. So I would like to see different divisions come in at every tribal health meeting, and I don't know how else everybody else feels. But
Sounds good.
we'll go with that.
we can do that.
Thank you.
All right, well, thank you. Oh, yes, Bing.
Thank you, Mr. Vice Chair. Joe, I heard you mention Health Committee. Set up again, other than what you have here. I'm glad to hear that you mentioned that again. And I hope that you do get that back up and try to get that on board again. I know it was a tussle last time around. And this time, I hope we can get it through this time and then you'll have that support and that everything won't be on your shoulders, and you'll have that support behind you, that letting you know what's taking place and what's going on. But I like to see that happen.
Thank you.
All right. Okay, thank you. Jennifer, the individual that was wanting to visit with us did we take care of that or?
Yes, that got taken, Patricia got taken
Okay,
care of.
all right, thank you.
I still got one more thing though.
Okay.
I joke, she just ruined my joke.
Oh, gee. All right, any other discussion with council? If not, I will adjourn the meeting for the day. Motion to adjourn by Bing, second by Jennifer. All right.